Myself, Dr. Anjali Khadia. I am presenting Magic Ball of Strabismus.
I always find difficulty in making my students understand the concepts of strabismus, even with the help of videos. I thought of a three-dimensional model will help them inculcate the concepts better. So, I thought of demonstrating all the aspects of squint using our magic ball of strabismus. This model was made out of a stand to mount the eyeball, a transparent plastic ball simulating the eyeball, dynaplast for the extraocular muscles, and sticks to demonstrate the fixed axis. To give residents an idea of extraocular movements and surgeries, we pasted the dynaplast in proportion to the human eyeball dimensions, which was 5 times smaller than our model. The sticks representing the fixed axis intersect at the center of rotation of the globe. The muscle plane and the listings plane were marked using cardboard sheets. This video demonstrates the various angles involved in the strabismus. The stable stick will be the optical axis. The movable stick, which is the visual axis, first goes towards the fovea, and as it is brought anteriorly at the first black point at the center of rotation, demonstrates gamma angle. Then, with the nodal point, it forms the alpha angle, and at the pupillary axis, it forms the angle kappa. Next, we move on to the extraocular muscle actions. We would like to demonstrate the action of two extraocular muscles, superior rectus and superior oblique, using our magic eyeball. The primary action of the superior rectus muscle is elevation, while the secondary and tertiary action being intorsion and adduction. The same has been depicted in our model. In primary position, the superior rectus muscle is at 23 degrees to the visual axis and exhibits all the primary, secondary, and tertiary actions of the muscle. When the globe is abducted to the 23 degrees, it acts as a pure elevator along the x axis, and on adducting the globe to 67 degrees, it acts as a pure intortor along the y axis. For the superior oblique muscle, the primary action is intorsion, and the secondary action is depression, and the tertiary action being abduction. Regarding the surgical concepts of strabismus, we have explained the procedures of recession, resection, adjustable suture, Faden's procedure, and inferior oblique weakening procedures. In recession, we have detached the muscle and attached it posteriorly using a double tape. In resection, we have detached the muscle and have taken the muscle anteriorly and attached to the original insertion point, with the bracketed area showing the resected part of the muscle. Here we have shown both the bow tie and the sliding noose type of adjustable suture using a paper tag. In bow tie type, the paper tag along with the muscle is inserted at the original insertion point and a bow tie is made, thereby weakening the muscle. In sliding noose type, we have tied another suture to the pre-existing suture, which can be tightened and loosened with ease. The physics behind the Faden's procedure is very intricate, and we have tried to make it simpler. In Faden's procedure, we will attach the muscle posterior to the equator so that the distance from the center of rotation to the new point of insertion, which is posterior to the equator, is reduced without any change in the primary position. When the eyeball is moved to the Faden side, then further shortening occurs, but on movement to the opposite side, there is no effect. For the demonstration of the inferior oblique weakening, we have shown its anatomical landmark with respect to the fovea. Subsequently, we have depicted the recession and the anterior transposition of the inferior oblique muscle. Our model is a prototype, low cost, do it yourself model which is easily modified according to the teaching requirements. This model turns residents' imagination to a visual reality.
Thank you, sir. Actually, it is a teaching model for the residents because the strabismus surgery and extraocular movement is very difficult to understand in two-dimensional. And three-dimensional, it is can easily visualize and it is transparent also. So what resectionalization procedure is there? So what happened after the resectionalization procedure? Whether muscle is relaxed or not, and
Very nice. So, Dr. Gopal Pillai.
Yeah, yeah.
Yeah.
Yeah, Dr. Anjali, it was really a nice presentation. I really liked it. It is one of the most difficult for the postgraduates to actually understand the movement of muscles. And you have simplified it with such a wonderful model. So congratulations, first of all. But let me ask you a couple of questions. Number one, what are the limitations of your model as of now, what you see? And what are the further improvements in the model that you would consider by the end of this next year? Thanks.
Limitation of this is that we are not able to demonstrate the actual feeling of the surgery. Only we are demonstrate the fundamental basic thing, and later I do better for the surgical and hands-on, like in the plastic bond.
Yeah, the Fadden you were able to do, but probably the recession resections.
Yeah.
That also, you may have a something like a Velcro which is attached from both sides, so that you can resect, or you can actually recess. So like that would be a little better from both sides. If you can have a Velcro sort of a system, that would be nice. And secondly, is it a little large to handle, so that it may fall down multiple times while you are fixing it?
Because larger size is there so that student can understand. It
Right.
means visualization is better. That is why I took a larger size.
But
We
whatever
can,
it is, it's a beautiful do-it-yourself for teaching the postgraduates as well as undergraduates the mechanisms of action. Congratulations, man. Thank you.